Every COVID-19 patient in hospital needs a ventilator. Pulmonologist Dr. Emmanuel Taban says there are other options available. He says patients can be managed with oxygen, anticoagulation therapy, or simply by placing them in the prone position. Well, Dr. Taban has made some time for us. He's able to chat to us this morning. Dr. Taban, a very good morning, and thanks so much for your time. Tell us about the procedure that you have performed. I think it's called the therapeutic bronchoscopy treatment. What is it, and what does it involve?
Bronchoscopy is not a new procedure. It's a procedure that actually been existing for the last almost 30 to 40 years and was initially discovered in Japan, actually, for one of the doctors who wanted to look into patient lungs. So we've been performing the bronchoscopy for other reasons, like for lung biopsies, for mucus extraction, and then also for looking for infection in the lungs. And that's always we've been looking for bronchoscopy for. However, when COVID-19 was discovered in 2019, there was a fear that bronchoscopy actually increased the risk of an infection. And on the literature, it was mentioned that actually patients with COVID-19 don't develop mucus plaques. And as a result, the World Health Organization actually issued moratoriums that patients with COVID-19, we should not do bronchoscopies on them. And however, during my management of COVID-19 patients, what I discovered that most of the patients will do very well during the first 5 to 7 days, 7 days of mechanical ventilation, and out of blue they start deteriorating, and actually they end dying because you couldn't put oxygen in their lungs. And in medical terms, there was an article which was published at Survival 6 Sepsis that actually what they described that those kind of patients, they would die of condition what we call H-type, means the lung becomes steep and they become fibrotic and the patient died. And initially I accepted the explanation, and I think I lost 3 patients. And I decided, you know what, World Health Organization has made a decision, but the reality is that nobody in the world, there was no literature to support that actually anybody has done bronchoscopy, whether it was in China, whether in Europe, or whether in America. There was nobody who actually looked at these people's lungs except post-mortem. And that's why once I decided one of the patients was sick, then I decided to put the camera into their lungs, and then that's when I found mucus plaques, and which was very tough.
So, Doc, in terms of COVID-19, which patients, at what stage, somebody comes to you, they says, I've tested positive, this is what's happening with me. At what stage or when or what type of patient would you, who is suffering from COVID-19, would you use this procedure?
Yeah, I think it's not really about the procedure per se. The procedure is really meant for people that have been in life support for more than 7 days, or that people have radiological evidence that they have mucus plaque. But what is most important about the discovery of this mucus plaque is about actually, it's not that you need bronchoscopy all the time to treat the mucus plaque. It tells you that patients with COVID-19 do develop mucus plaque. And that means we can use preventive measures to prevent formation of mucus plaques. So initially, before they actually get into bronchoscopy, we can use mucolytics to break out the mucus plaques. Okay, and you can also use a physiotherapy to allow those people to be able to get the mucus plaque. And when they fail, and when they're in mechanical ventilation for 5 to 7 days, then we consider mucus plaques.
So what are the precautions around this, Doc? Because we probably have many people going, okay, this is the miracle answer. This is what we've been waiting for. If we have COVID, this is what we need to go and do. What are the precautions around this?
I think the precautions that, I mean, it's an invasive procedure that need to be done by a trained specialist, like pulmonologists. They have to have expertise, and you have to have a staff, anesthetics, and that. And it's not, again, not done under normal people who covered. You have to be having severe COVID, and you have to be in a mechanical ventilation, and at least for 7 days or 6 days, or you should have other indications, and that's where you can do the bronchoscopy. But the reality is that bronchoscopy really is a life-saving. It does reduce mortalities, and also if we use appropriately, the risk of death or complications is less. And if you use in negative pressure room, the risk of staff being contaminated for infection is almost zero. Because midstream, since I've been performing the bronchoscopy, none of my staff, neither myself, acquired COVID-19. So there were this unfounded fear that is dangerous. It increased mortality. But the question that, how do you increase mortality for someone who's going to die anyway? So saving that person's life is more important than fearing for your own life.
Doc, if you're able to tell us, I mean, how many COVID-19 patients have gone on to walk out of your facility with you using this and with you tackling that mucus plaque?
I think currently probably I've done almost up to 140, and I think most of my patients actually survive. Most of them survive, and mortality in midstream is quite lower as compared to anybody in counting area. We have almost like, up to today, I think we have like almost 884 people that were on life support, and our mortality is sitting at about 28% on ventilated patients. In South Africa, the mortality currently is sitting between 55% to 68%. That's a huge gap of 30%. So clearly, there have to be some benefit if they say, to argue against, because if the mortality is low in midstream on ventilated patients, why it's not low in other countries, in other centers? And I think, for me, there's a lot of benefit, and mortality speaks for itself.
Doc, have you shared this knowledge with your peers? Obviously, they are aware of what you've been doing and how you've been treating this. Why aren't we using it more in other facilities as well?
Well, a lot of colleagues are using them now. There are quite a lot of pulmonologists now are using their bronchoscopies, especially the young pulmonologists. And currently, Baragwana also is trying to set up a center for bronchoscopies. I think by this coming week, Monday, we're working on it. So now people are trying to do them. But again, you need to have the expertise. And if you know that the pulmonology in South Africa, we're quite very few of us, maybe about 97, and most of the people are elderly. So people that are active practicing, like in Victoria, there are 2 of us who are young who can do bronchoscopies. And then count in Joburg area, maybe about 4 or 5 of them. So the question is about, I think we don't have a huge number, but I know that people like cardiothoracic can be able to perform the bronchoscopy also.
All right, Dr. Emmanuel Taban, I'm glad we got a chance to talk to you, because I suspect that after this, you are going to be fully booked and not able to speak to anybody after this. Thanks so much for your time there, pulmonologist Dr. Emmanuel Taban.